Welcome back, everyone, to Einstein's Eyes. Thank you all for being here, the learned, the curious, the lifelong learners. This is your go-to channel for all things related to ophthalmology and eye health, innovation, healthcare policy, tech, private equity, finance, pharmacies, drug interactions, all things ophthalmology related. We have two special guests today. Actually, not a special guest. We have my partner in crime, Dr. Jon Ditkoff. Jon.
Hi, everyone. I'm a general ophthalmologist specializing in cornea. I've been in practice for 30 years in northern New Jersey. I did my training at Albert Einstein, hence Einstein's Eyes, where I met Carl. And then I did my fellowship in cornea, but I've been practicing now in northern Jersey. Today, I happen to be upstate New York, so it's a little bit different for me. Excuse the casual attire. But it's really an honor to have someone who I've gotten to know, taken care of a great deal of my patients. I've taken care of his patients, Dr. Agarawalla. I'll let Carl introduce him.
Great. Thanks, Jon. So I'm an Alaska Anchorage. I think most of you know that I am a fellowship trained oculoplastics and neuro-ophthalmologist, focusing really on oculoplastics nowadays in Anchorage at Ophthalmic Associates. We have a special guest, PK Agarawalla, a renowned neurosurgeon at Rutgers. His background speaks for itself. Harvard undergrad, HMS, Harvard Medical School, trained at Harvard, I believe, and now professor at Rutgers. And we're going to talk about neurosurgical problems that affect the ophthalmic pathways, the ophthalmic tract, that can affect your visual fields, etc. Dr. Agarawalla, please introduce yourself, and thanks again for being here.
Well, thank you guys both for having me. Dr. Rosen, Dr. Ditkoff, it's been actually a real pleasure to collaborate on patient care with Dr. Ditkoff, and really enjoyed having me, talk a little bit about the eyes and the brain. It's a fascinating topic and one I love. I'm an associate professor of neurosurgery, board certified at Rutgers. And I did my fellowship training in skull base and open vascular neurosurgery. So this is definitely an area of interest and a passion of mine.
Fantastic. So let's start talking about the pituitary gland. Can you explain its role in the body and why it's referred to as the master gland?
Sure. So I think everyone's heard of hormones, and hormones are essentially small molecules and compounds that go throughout the body and can have end effects on different organs. And that whole system is called the endocrine system. And one of the main drivers of hormones is the pituitary gland. That's why it's called the master gland. The pituitary gland is the master regulator of the hormones of the endocrine system. And as you can see in this diagram description, it produces a number of hormones that then affect the end organs. Really importantly, the pituitary gland also sits in a unique spot in the brain where it has a very close relationship with the optic system. And in particular, it sits in what's called the sella, which is short for sella turcica, or Turkish saddle, because this area resembles the Turkish saddle. And you can see the pituitary gland on this MRI with the white arrow on the left panel. That's a normal appearing gland. And the green arrow is showing its relationship to the optic apparatus and the optic chiasm specifically. And so tumors of the sella, which include pituitary tumors, will grow and put pressure on the optic chiasm, leading to visual changes. The classic findings on a visual exam is to have loss of your peripheral vision on both sides. And it's in the temporal fields or the outside fields of your vision. And so it's termed a bitemporal hemianopsia. And actually, in the management of these pituitary patients, I send them to Dr. Ditkoff to do visual field testing. And this is what we're looking for, to see if the compression of the optic chiasm is causing visual loss. The reason this happens is that the brain is organized in such a way that the right side of the brain controls a lot of the left side of the body and the world, and the left side of the brain controls the right side of the body and the world. So when there's pressure at this chiasm, which is a crossing point, it affects fibers that ultimately see the outside of the world in your visual field.
They're looking out as if this represents the black represents on the right side represents the outer part or where your ear is, and the left side represents the outer part or the left side, and the center part would represent where your nose is. So that's why it's bitemporal hemianopsia, and it blocks out the both lateral aspects of your visual field and compresses what you can see.
When you have lesions in the pituitary, they can actually be a number of different pathologies. We call them cellular pathologies. And one of the most common is what's called the pituitary adenoma, although the modern classification has changed a little bit to a new term called the pituitary neuroendocrine tumor, or PITNET. But for the most part, I think everyone's still calling them pituitary adenomas. And it's a relatively benign tumor of the pituitary gland where some of the cells of the pituitary start to grow and can get larger and can cause problems. Now, it's really important to have a multidisciplinary approach in the management of people with pituitary problems or cellular pathologies. And really, you need to have an endocrinologist, a neurosurgeon, an ophthalmologist, and then ultimately, if we decide to do surgery, an ENT rhinologist. And the reason why the endocrinologist is so important is because we need to get a baseline set of endocrine laboratory workup to see if the tumor is over-secreting certain types of hormones that might lead to other problems, or to see if some hormones are low and they need to be replaced. And all of that is done, with me in conjunction with an endocrinologist. One of the more important things about this is that there's a certain hormone called prolactin, and sometimes these tumors can secrete a lot of prolactin called a prolactinoma, and those tumors are treated not with surgery, but actually with a medication. Usually cabergoline is the drug of choice now. So it's just important to have a multidisciplinary approach so that we can find the right treatment. And I'm happy to talk a little bit about surgical approaches, radiation approaches, other pathologies, whatever you guys find interesting.
Yeah, let's just do a quick summary of surgical approaches that you would consider or discuss with a patient.
Yeah, sure thing. So it just depends on kind of where the tumor is and how big and how it's shaped around the chiasm and some other critical structures like the carotid arteries that are there. But generally speaking, for the majority of my patients with cellular pathology, most modern neurosurgeons are now doing endoscopic endonasal approaches. And this is done in conjunction with an ENT surgeon. My ENT skull-based partner is Dr. Wayne Shea. He's also with me at Rutgers, and we do all of our cases together. He's phenomenal. And basically, the rhinologist or the ENT skull-based nose surgeon will use a high-definition long camera, like a telescope, Hopkins telescope, connected to a high-definition screen. So I'm able to look at this camera and a big screen in the OR, and we use this camera to go through the nose up to the sella and the pituitary gland, and then use very fine instruments with two surgeons together, Dr. Shea and myself, for example, working to take out the tumor. So it's a beautiful picture, actually, and you can see that that's exactly what our endoscopes look like. They shine a light deep through the nose toward the sphenoid sinus, which you have there, and the pituitary gland, which is right there, pushing up on the optic chiasm. So it's a relatively good representation of what we're doing. So we're able to take out the tumor in a very minimally invasive approach with essentially no incisions because it's all through the nose.
Right, right. So just for the audience, this is the optic nerve. Here's the chiasm. The pituitary gland is here, and it's compressing or pushing upwards on the chiasm. This is what caused the visual field defect, as Dr. Agrawalla discussed earlier.
The only thing I would say is that not to forget about other management options. And I think having a multidisciplinary team is really important. So I was part of a group that looked at a different type of cellular pathology called craniopharyngioma and a subtype called papillary craniopharyngioma. And, we were able to show that there's actually some medications that you could take to help shrink those after surgery or potentially even up front. And in addition, radiation is also, a good option. And so I've been very lucky to use a CyberKnife machine to do my radiosurgery for certain types of lesions. So, just really need to have a good team approach in the management of any lesions that are basically in this region.
Right. And what complications would you discuss with a patient, or what do you look for?
Yeah, that's a good question. I mean, I think one of the risk factors that can happen is leakage of cerebrospinal fluid. So cerebrospinal fluid, it bathes the brain and the spine, and it's clear. And sometimes you'll do the surgery and you have to open up the thick covering of the brain called the dura mater, and that will allow fluid to escape. Now, in the surgeries, we always try to repair this or patch it off and try to prevent the leakage, but sometimes that can happen. Infections for any surgery can happen. I would say that's somewhat rare, despite the fact that you're going through what you would think is a dirty nostril. For whatever reason, it tends not to be a big issue. And then there's always hormone issues. So you can always damage the gland or the stalk, and there can always be a risk of either temporary or permanent damage to hormones. And that varies a little bit with the size of the tumor, the pathology. And so I kind of counsel it based on, patient-specific, case.
Good. That's fantastic. Yeah. So as a neuro-ophthalmologist, when I did neuro-ophthalmology and I took care of these patients post-operatively, I would always ask them, do you feel a drip? Do you taste something sweet? And is it chronic? And that was a tip-off that, along with a headache, that maybe something was going on, that there may be a leak. And that can last for a long time. That's easy to miss for lots of folks, at least on the neuro-ophthalmology side.
I'm going to add a couple of things though, Carl.
Okay. All right, John, go ahead.
Yeah. So I think this was a great topic. As an ophthalmologist, and I've had the real great fortune of working with Dr. Agarawalla on, at this point, a significant number of patients. I've seen how wonderful he is with the patients. You think of these neurosurgeons can be very intimidating, could be overwhelming for a patient being told they have a brain tumor or some problem otherwise in the brain. I've been amazed how he has that common touch, which really goes a long way. And I think they're put at ease in a lot of respects. But so the patients I've been seeing over the last 30 years with brain-related issues that affect the eyes, things like occipital parietal lobe tumors, which affect the peripheral vision as well, strokes for those part of the brains. We could spend hours talking about all these different things, aneurysms in certain locations, cavernous sinus tumors. So we're not going to get into all that, but maybe we will talk again. I guess one question I have is, I have the impression that it's that I become very important, and I kind of want to know my role. So I've seen so many people over the years that have lesions in the pituitary gland, and it's really good news. Sometimes I look at them and I do a visual field test, I check their optic nerves, and essentially they're functioning normally. So at that point, Dr. Agrawalla, I mean, so you're being told it's not affecting their visual pathway. You know the size of the tumor. You've looked at their MRI. How often are you going to be monitoring them for change? I mean, obviously it depends on the growth, but in general, how often are you going to be monitoring for growth, and how often should I be monitoring for change in their peripheral vision or their optic nerve?
That's a great question, and I think we actually we're sharing a patient right now where we're actually having this conversation about what to do for a Rathke's cleft cyst, which is a different type of cellular pathology. And my approach is, let's say you're a patient and someone does a scan because you have headaches, or for whatever reason you find out you have a pituitary tumor. Obviously, it's a stressful situation. It's concerning. You're freaking out. But before you rush to any kind of surgery, I think you have to have everybody come on board. Now, when someone comes to me and they have no endocrine problems, as per the endocrinologist, and then Dr. Ditkoff, you do your testing and everything, say, hey, look, the eyes are okay. Maybe the tumor's not that big, it's not compressive, or maybe the body is adapting to it. I don't have to rush in and do anything, and we have that conversation. Now, what I like to do is I like to do early follow-up, kind of just from when the diagnosis is made or when we're doing some early evaluation. So maybe I would do like another follow-up in 6 weeks or 3 months, and then have a conversation again about, well, okay, this is the chances of it growing. This is the chance of, you're at a low chance of having it cause vision problems. You're at a higher chance based on the size, for example. And then I sort of spread out that follow-up, maybe 3 months and then 6 months and then a year. But really emphasizing to the patient that they should, come back or call if they're feeling any difficulties. I will say one thing is that once the vision goes, it is not a guarantee that we can bring it back with treatment. And so it's always better to get it done before you lose vision, because you just don't know what's going to happen if you do lose vision, if it's going to come back. But that's kind of my follow-up scheme. But the small ones you can follow for years, and there's no problems. Some of the bigger ones you would probably want to offer surgery or some type of treatment. My cutoff is about 1 centimeter, which is kind of what they call a macroadenoma. But it also depends on how far it is from the chiasm and stuff like that.
So I'll add one of my, this is a story that I guess has stayed with me, because it was one of my first years in practice. And I saw this nice lady who was a teacher in Newark, drove to the office that day, and she said, no, I've just been having some mild problems with my eyes. She thought I should get checked. And we checked her, and I was blown away. I mean, in one eye, she was legally blind. The other eye, she had lost significant vision. She had absolutely no peripheral vision on both sides in either eye. And she drove there that day. It just shows the power of people in terms of denial and how it was coming on slowly enough, probably over years, where she just kept adapting. And within days, she was in the operating room, had a large pituitary mass removed. She's still my patient 30 years later. She regained vision completely in the non-affected, the eye that was mildly affected. The eye that was affected was definitely affected significantly. But I think, it's a great story for me, that a lot of people don't go for eye exams and don't go when they're having problems, but we should, because we can pick up a lot of things.
Yeah. So just from a neuro-ophthalmology perspective, again, so I've seen folks where they do get better. Now, again, you're right, Dr. Agarawalla, but I would say if you intervene soon enough, you can see that bitemporal defects soften up or lessen. And I have seen multiple cases where that has occurred. I will also say that as a neuro-ophthalmologist, when you look at the optic nerve, there's something called bow tie atrophy, which you see, which affects the nerve fiber layer. And OCT can help you pick that up for folks like John and I who have those instruments. But for me, really, the tip-off is optic atrophy, and a patient has a sense that their visual field is constricting. And that's a tip-off for me. And then I'll do my thing and I'll image, and then I'll get it to a neurosurgeon. Yeah. So John, anything else?
Do it. That should do it. It was really great. Very informative.
Okay. Yeah, no, perfect. So once again, I'm going to say, Dr. Agarawalla, thank you for sharing your expertise with us. And thank you to all the viewers who tuned in to Einstein's Eyes. Our channel is slowly growing. If you did find this discussion helpful, as I mentioned, please like and subscribe and share with others who might benefit from this information. And until next time, keep your eyes healthy And thanks a million, guys. Thanks, Dr. Agarawalla.